Tekrar teşekkür ediyoruz. Öğleden sonraki oturumu açmak için, katılımınız için teşekkür ediyoruz. Öğleden sonraki oturumumuzun ilk konuşmacısı Profesör Doktor Christopher BREDESON. Kendisi ASBMT'nin başkanı ve otoimmün hastalıklar için nakil linyeri konusunda konuşacak. We would like to invite Dr. Christopher BREDESON, President of ASBMT. Dr. BREDESON is going to talk about transplantation for autoimmune diseases. Please, Dr. BREDESON.
Good afternoon, and thank you for being here. Okay. I'd like to start, obviously, by thanking Merrill and the organizing committee for having us. It's my second time in Istanbul. It's the most beautiful city. It's the most amazing place I think I've ever been in my life. And we spent the morning on a boat cruise, and Hari and I were trying to figure out how to get a 1 month sabbatical just to hang out. We're like, wow, we could write a paper, we could have a meeting. So, it's just a beautiful experience for us. And when I go home, I'm always depressed because the food is so much better here. The fish is fresher, the vegetables and the fruit are fresher, the sun is brighter. So, anyways, thank you for having us. I'm going to talk today. You're going to get tired of hearing me today because I'm talking about 3 different things. This is probably the most normal of the talks that I'm going to give. It's about some work that our group has done and what goes on in the world of autologous stem cell transplantation for autoimmune diseases. And since 1995 in Ottawa, we've been pursuing this platform to cure, hopefully, bad autoimmune diseases, and I'll tell you why we think that might work. So just briefly, by way of reminder, autoimmune diseases can affect really any tissue or organ in the body, and we know that from graft versus host disease, which is, a severe form of that, but autoimmune diseases can affect really any part of us, and as such, lots of potential if this works to improve things. And if we think of autoimmune diseases, which probably as hematologists we don't spend a lot of time thinking about, but there's really only not really much that's good at addressing the illnesses. We mostly deal with symptomatic relief. You can replace what's missing, such as in diabetes. You can use non-specific suppression of the immune system without actually really changing the immune system. You can, as we saw yesterday in the excellent case presentation, you can use therapies to stimulate the cell line that's suppressed, if that's a problem. Or we thought the work from with aplastic anemia, you can actually replace the immune system and get rid of the disease. So we can't really necessarily replace the immune system on autoimmune diseases because of the toxicity of allotransplants, but maybe we can have the immune system start over. So just to remind people that there's lots of things available for treating multiple sclerosis, but despite that, once it moves from just relapsing, remitting disease to sort of disease where you accumulate disability, there's really not very much that works. And you can see that over time, people accumulate disabilities. So why would auto transplants work for this illness? First of all, we're going to try and do it to reconstitute the immune system. And the process that we take is multi-step. We want to remove from the graft that we give people autoreactive lymphocytes, so the cells that are causing the problem, we want to get rid of those. So we use cyclophosphamide to mobilize the graft, and then we CD34 select the graft. So while we're giving back is immature hematopoietic stem cells. And then we really want to, which is different than other centers that have done this, really hit the immune system hard, the residual immune system, the body, to try and ablate the immune system as much as we can. And then, because we know it's a CNS illness, we'd like to get drugs in the conditioning regimen that can get into the CNS central nervous system and kill any resident cells there. And then obviously if we're going to use a very intensive conditioning regimen and a CD34 selected graft in people who have pre-existing health issues, we need to provide quite significant supportive care. So this is the regimen that we adopted initially, obviously before IV busulfan, it was oral busulfan, but this regimen is what we've been used since about 1995. Slightly reduced a dose of busulfan, a sort of 3/4 dose busulfan, 4 days of cyclophosphamide at 50, so lots of cyclophosphamide, 6 milligrams per kilogram of thymoglobulin, and a CD34 selected graft is reinfused, and then we try and promote hematopoietic neutrophil recovery, at least with GCSF. So a sort of short version of this for today. Early on, the complications are as you would expect. Here we see North American CTC grading of toxicities compared to several hundred auto transplants for lymphoma in our institution to see how they compare. So these are mostly beam auto transplants for lymphoma. This is the MS regimen we saw. You can see that there's mostly grade 1 and 2 toxicities, but we did actually have one fatality in the original trial related to VOD with oral busulfan in the days before pharmacokinetics, and that actually led us to decrease a little bit the dose of busulfan, and we've not had further troubles. And you can imagine that you would get all the usual things with a transplant. Late complications, because we follow patients now for over a decade. The shortest follow-up on the trial initial is a decade. So obviously we run into gonadal dysfunction, viruses wake up. There is some secondary autoimmunity that not fully understood but happens and is generally easily manageable. And then there have been cases, although we have seen cases inside the transplant population, outside of secondary AML, in patients who've had mitoxantrone as treatment for their progressive multiple sclerosis. Oops. So does the approach ablate the immune system, and can the immune system effectively reconstitute from hematopoietic stem cells? And the answer would be, we think yes. So baseline, you have a reaction to tetanus toxoid. 18 months after transplant, there's no response to tetanus toxoid, and then at 24 months, you can see that the response has returned, so that we have immune reconstitution. This is just one example from an extensive collection of work demonstrating that. So what about clinically? So, and I'll show you some graphical representation of some of this information because it's more impressive when you see it. So after this transplant, we see no disease activity in patients followed at a minimum of a decade. No opportunistic infections other than the viral reactivation, so we're not at PCP or mold infections. And as we said, the immune responses have recovered. We see that thymic output recovers in these patients who are mostly young, mostly in their 30s and early 40s or younger. And then we have a polyclonal recovery, and then we can see that there are some features that you would anticipate with profound immune suppression initially, that there's a delay in recovery. And surprisingly, maybe not surprisingly, in some patients there's a return of the lymphoid population providing anti-myelin basic protein, which is sort of what we would think of as a marker for the MSs coming back. And yet we haven't seen that clinically in any patients. And then in some patients where we've done lumbar punctures, we've seen the hallmark oligoclonal bands that we all remember from med school related to multiple sclerosis disappear. So this shows that we more or less can safely do it. Obviously, one death is in this initial trial of 24 patients was not good, but the other patients are all out, and this is an older slide now. You can see how they are doing. And this is where I think the things become quite interesting, is that this line demarks when they had their transplant, and before that these little triangles show how many clinical relapses they've had where they get numb in an arm, or they lose their speech, or they need therapy for multiple sclerosis activity. And you can see that after their transplant, there's no more relapses of the disease. It's not that it's decreased, it's absent. And you can see this similarly by MRIs. So here's again new or enhancing lesions. We all think of gadolinium enhancing lesions in multiple sclerosis. And here you can see beforehand lots of positive scans with the triangles and the little dark spots are where there's a scan, but that's not positive. And then you can see that after the transplant, nobody has even one scan that shows disease activity in their brain. So we've essentially stopped the disease at the time of transplant. The stars are two people who went off to have the Marconi procedure, where they dilate their posterior vertebral veins, despite our best advice, and this gentleman was the one who died of VOD. But lots of disease, no disease. Sorry, I'm twitchy fingers here. The gentleman yesterday, I thought was him, but it's not, it's all of us. So that sort of says, okay, but what happens? So sometimes we say, in some patients, there's been some progression. So this is a number of patients who've had some worsening of their multiple sclerosis score, their EDSS. And you say, well, how, I just said there's no activity, and yet they're worsening. And so I use the analogy, we go and see your beautiful tulips here, right? But if you don't water the tulips for a long time, and then you water them again, some of those tulips will be irreversibly damaged by the drought and will die. And some tulips will recover. And it's the same in your CSF. There's some neurons or axons that have been so damaged prior to the transplant, but they eventually die. And so you can have some disability accumulate in some patients, but you don't see any more disease activity. So there's sort of the dying of the wounded. And we see actually a similar number, about a third, I think is the next slide, of people who actually have improvement in their performance status. No, this is about your brain. So one of the sad things about MS is that your brain atrophies at an accelerated pace compared to the normal population with time. And this shows at within the blue is the same sort of brain shrinkage that occurs as we age in a year to year, and that in our MS patients it returns to baseline. So their brains no longer are shrinking any faster than our brains are shrinking who don't have MS. So we really have stopped the axonal and neuronal loss in these patients. And this is what I mentioned before, that I showed about a third of patients have some, a small number, a third have some worsening, but we have about almost a third to a half of patients who have improvement in their performance status with time. So you can have loss of some damaged neurons, but you can have regeneration over time. We don't understand fully how that works, obviously, but clearly these are, and if we, the time we have a picture of somebody who was walking with double crutches, and then we have the picture of them skiing down the mountain. So there's some impressive recovery. This is one of these crazy sort of a heat map of disability in different patients, showing whether they had worsening or improvement over time in their functional systems related to their overall disability score or the sub-scores related to the particular senses. And you can see that the red is, it's sort of opposite what you think. Red is that they're getting better. I keep telling Harry to change the colors backwards, but red is you're getting better and green is you're getting worse, and yellow is sort of in between. And you can see that there's much more red and yellow than there is green in these patients. So overall improvement. And how does that translate into quality of life and function for these patients? So we had, before the transplant, only a quarter of the patients were working, and after the transplant, over half of them were able to go back to work. Long-term disability, how many people were unable to work and were on government support from or not on it, so 40% were, 60% weren't, and then up to 80% were able to get off of disability. surprisingly, or maybe not surprisingly, when you regain your function and your independence, your ability to have relationships improves, and so we see patients increasing in their proportion of them in a relationship, which if you're romantic, that's a good thing. And driving, probably and I don't know if I'd ever want to drive in Istanbul, but driving is a hallmark of independence as well. And you can see that again, a significant proportion of patients improved in their independence, their ability to function in society. So can the risks be modified, right? We had toxicity, we had one death. We've changed a little bit what we did so we don't have any more deaths, but there's still a moderate amount of toxicity. These are tough transplants. These are as hard a transplant over the first 2 years as an allo transplant because we've given a large regimen and a CD34 selected graft, so they require a lot of supportive care for infectious issues. So if we lessen the intensity, would we be safer? So this sort of shows from the literature, we're on the bottom, different populations, registry studies, just with cyclophosphamide and ATG, BEAM and ATG, another one of BEAM and ATG, and you can see that the proportion of patients with infections is about the same except with Cytoxan, and that the mortality is about the same in these regimens. So not a huge difference in safety. But the difference is here, where we see that if you just give Cytoxan and ATG, as is done in Northwestern, instead of having no disease progression over time, we see that there's a continuous gradual loss even within the first 5 years of control of the MS. So it might be helpful, but it's not fixing the problem. And I'd say if you're going to undertake the activity of an autologous transplant for a disease, you should that's not a malignant disease, you should make sure you're curing it. And similarly, with Richard Nash's group, which is also a high dose or a moderate dose regimen, you see disease progression from Seattle. So yes, you can decrease the toxicity a little bit, but you're probably at the cost of controlling the disease. And then you could get into a strategy which we can think about but haven't implemented yet. So you said, well, if you have really bad disease, you need the really big therapy, and if you have less bad disease, maybe you could get away with a lesser therapy, but we don't know that. And this is sort of our approach to thinking about it, and I'm not going to spend time here because I want to talk about a couple other diseases. So for MS anyways, high-dose chemotherapy can ablate the immune system. We've shown that because we lost reactivity against vaccines and we lost activity against our brains. And you can see, as we said, despite, we could see that there was no further immune activity against the brain, either by clinical relapses or MRI activity, and that people actually do reconstitute a functional immune system as we would hope they would, since we're giving them hematopoietic stem cells. And we can see improvement in their disabilities as they return to normal life. And this is just to show actually our activity now. Those numbers don't match here, but we've done about 70 MS patients, some myasthenia gravis patients, chronic inflammatory demyelinating polyneuropathy, neuromyelitis optica, and stiff person syndrome. And I'm going to just touch on a couple of those diseases. So here's our experience. We published not too long ago on 7 patients with myasthenia gravis who had very refractory myasthenia gravis. And again, we can see the same sort of model of autoimmune disease. Here's a transplant beforehand. This person had been intubated a number of times because of respiratory muscle weakness. They'd been in the hospital a bunch of times related to their disease, emergency department visits, etc. And then lots of on multiple therapies for their disease, and you can see now even within a couple of years or a year of transplant, almost all of them are off of their anti-myasthenia gravis medication and are no longer having the problems that they had beforehand. This one took a little bit longer. It was the most severe, but even now, for a number of years now, maybe 7, 8 years, has been off of all therapy for myasthenia gravis without recurrence. So not everybody with myasthenia gravis, obviously, but highly selected patients who have very bad disease early on and are failing therapies. And then we have this funny disease called stiff person syndrome. The first time I saw a stiff person syndrome patient, I thought it was a psychiatric disorder, and the person was just kooky, because they said when they get startled, their muscles go rigid, and it's a progressive activity, and they can go from just having tight muscles to people who have it very severely can break bones, can have respiratory dysfunction, can require intubation. And actually it's a true autoimmune disease with an antibody that mediates the illness. And we saw this first lady, we transplanted, and then we've gone on now to do 5, and this is a publication of the first 3. And this is one of our recent patients, and this is basically her view of things. It's a bit of marketing, I guess. Next step is my last-ditch effort of having a life, of giving my husband back a wife and my kids a mom. And she had a kind of a rocky course, but she's now no longer have these startle effects. The first person we saw in that regard had a coded in our consultation visit, because she was so anxious that she triggered an event, and we had to code her and have her intubated in the consult room. And she's now back living independently as a personal trainer, no longer having disease problems. And we know she's cured because she was sitting in a cafe and a car crashed right through the window of the cafe, and she didn't have an event. So we figured that proves that you're no longer going to have the startle problem. These are all the people in, well, geez, just like the guy that Harry has related to the neurology program helping us. So I'm just going to talk a little bit in the few minutes I have left related to another study that I got to be a part of when I was in the States, as was Hari, and this was autologous stem cell transplantation for severe scleroderma or severe systemic sclerosis, and it was a randomized trial led by Keith Sullivan over, again, like 15 years of work to get this done, comparing it to monthly pulse cyclophosphamide, which was felt to be at the time the standard of care for people with scleroderma. And basically, bad scleroderma is bad. That's the take-home message. I think people know that or familiar with that. And you can see that if you have internal organ complications separated from just your skin disease, that your median survival is 8 or 10 years. And there was mouse data that suggested that you could fix this illness. Goes back to Marmot, maybe 25 years ago or so. And they thought that the same approach, if you could use an ablative transplant with immune reconstitution, you might lose in the short term because of toxicity, but you would gain in the long term from sustained disease control. So that's why this long window, almost 5 years out. So randomized trial of people with quite bad disease to collection with cyclophosphamide and GCSF, GCSF and steroids. You have to give steroids so you don't get a flare of the scleroderma during the time. And then ablative transplant, TBI with some lung shielding, kidney shielding, because their lungs are already damaged in these people often. Regular dose of cyclophosphamide, a fair amount of ATGAM, and then again a CD34 selected graft. So trying to kill the immune system, put in some stem cells without a bunch of mature immune cells and see if it works. And the alternative was first dose and then pulses of cyclophosphamide every month for a year. And that was felt to be standard of care for these patients. Then there's a crazy primary outcome measure, which we won't go into because we'd be taking an hour just to explain it in detail, but all of these things are bad, but death is worse than having increase in your skin thickness. So and so you sort of ranked all these these outcomes by patients in each arm, and you could decide whether, 2 patients who died are the same, but if one patient died and the other patient had all of these, they were still better off than being dead. So you can sort of work your way through ranking who has more disability than the next patient, and they come up with this composite score, and it's been validated as a good outcome model. So again, small numbers of patients. The study actually closed early because it kind of NIH got tired of spending money for a slow accruing study, but it was hard. In the States, it was actually another paper published about how hard it is to get it paid for. The insurance companies just wouldn't pay for people to be on the study in the States, except for these ones. So, you know, females, younger patients. Smoking is important because it correlates with bad lung troubles and scleroderma, so you want it to be stratified on smoking. And these are again, this is a short version of the presentation. Here's some efficacy outcome. The outcome measures, this primary one was different, meaning that the transplant patients had fewer bad outcomes than the cyclophosphamide patients, ranking through those outcomes. But when you look at secondary outcomes, a shorter window. Event-free survival is defined as death or progression to dialysis or significant worsening of your pulmonary function. Looks a bit better, and then the mortality overall was the same. Going back on disease-modifying agents for the scleroderma, obviously more people with cyclophosphamide were failing and required reinstitution of their medications. Development of pulmonary hypertension or congestive heart failure, two complications known with progressive disease that portend your doom, were higher in the cyclophosphamide group. And this just shows the event-free survival statistically better here. It looks better too. So some initial troubles and then things pretty much plateau. And here we continue to see people falling off, although there does seem to be a plateau, albeit lower. And then overall survival so far is not, and the overall survival also better. And too soon to know what those curves are going to look like at, say, 10 years. So then the same question as well, is it safe enough to do because of the mortality? And so it was compared to the European trial that was quite similar, although they used a beam conditioning regimen with ATG and they didn't manipulate the graft. And it's really, you can't compare the studies, but everybody thought the Scott study was going to be too toxic, but you can see the mortality certainly not worse with the Scott study from therapy, and certainly the proportion of patients going on to therapy was less with the more intensive regimen to control the disease. So that's sort of a very quick overview of some autotransplant activity for diseases that, if we went back to the first slide, cover a lot of the organs and tissues in our body. Multiple sclerosis. We didn't talk in detail about neuromyelitis optica or having a senior moment, the neuropathy. We talked a little bit about stiff person syndrome and myasthenia and scleroderma, and I'd be happy to answer any questions, but I just highlight again that Harry Atkins in our group has led this mission for the last almost 20 years at our center. And Keith Sullivan spent 15 years of his life getting the Scott trial done, and so they deserve our respect for those commitments. Thank you very much. And I think I might have saved us some time. Any questions?
We can take a couple of questions. Yes.
Thank you very much. I'd like to learn about the timing of transplantation in MS.
Okay.
And after that, is there a threshold for the EDS score in MS as well? Because I would just like to learn your opinion. Would you transplant a patient with an EDS score 8, for example?
So when I was in the States, I was in Ottawa when we started. I left. I went to the States. We were involved in a trial there in Medical College of Wisconsin before I came back to Canada again. And in that study, early on, we transplanted patients who were in a wheelchair, which is what
Yes.
7 and 8 is in a wheelchair. And that was a safety study, and so, you know, you could do it. It's harder if you're not mobile. All the complications of not being mobile with a transplant are worse. But I wouldn't do it as a therapy, because the benefit that you can get is really one of preventing disease progression. And if you're already in a wheelchair, and usually that's, you know, it's unusual that's you're in a wheelchair and there's nothing else wrong. Bladder, bowel, cognitive changes, they seem to, you know, they kind of run together, although the EDSS is weighted towards mobility. So no, we wouldn't do that now, not because we don't want to help those people, but we should be getting them sooner. And so the EDSS is sort of, in the study, was sort of 3 to 5.5. And an EDSS of 3, for people not familiar, you would not know if you were at a wine and cheese or a cocktail party if somebody has